Good morning and welcome to the Health Innovation Network Innovation Insights series of webinars. And today we're going to be discussing accelerating NHS transformation through industry collaboration. My name is Nicole McGlennon and I am the Chief Officer for Health Innovation East Midlands. And I'm delighted to be joined this morning by colleagues from the Association of British Pharmaceutical Industry, the ABPI, Brian and Nabil, along with colleagues from Health Innovation East Midlands, Jay and also Siobhan from Eli Lilly, and delighted to be with you for the next hour. So let me take you through the agenda. So we will have some introduction and some scene setting. I will kick off with some scene setting from the Health Innovation Network. And then we will move into the bulk of the agenda, hearing from ABPI colleagues and case studies, case study from Greater Manchester and Eli Lilly, and then a discussion around the principles for successful NHS and industry collaboration, which I think we can all certainly consider the importance of that going forward with the challenges that we're facing within the NHS and healthcare. And then we can go on to some questions and discussion, which we do want to try to have ample time for. So I hope that meets everyone's objectives for today. So with that, let's take a look at the key points for understanding the opportunities for NHS colleagues and systems to collaborate with industry and address local health challenges. Secondly, to provide actions and practical learning and insight to help organisations and NHS systems build collaboration and the support that we can offer to you on that from Health Innovation. And then the last point is about signposting support locally as well as nationally from the Health Innovation Network, and to help capitalise on collaboration with skills and objectives that we can bring to the table. Thank you. So just very quickly, if you wouldn't mind, if we could have a quick poll, which I think Annie, who's steering the slides, will organise for us. If you can give us an indication on which organisation and structure you're from, that will be particularly helpful just for our own understanding of how to engage with you in the future and going forward. That would be terrific. Thank you. We'll just give a moment for that. Thanks, Annie. It would be great if we could take a quick look as it's building. That's super. Thank you. Okay, so I want to just literally have a couple of moments and introducing the Health Innovation Network. I'm sure many on the call are very familiar with the network. Just to give you an idea, we are health innovation adoption experts and have worked in collaboration with industry and the NHS for over a decade. You can see some of the numbers there for yourselves. So since 2018, we have impacted 3.8 million lives through our national programmes and innovation initiatives. We have supported over 340,000 hours of healthcare and capacity back into system working since 2020. And when it comes to economic growth and investment, which we have a commission for with the Office of Life Sciences, we have invested and leveraged more than 2.6 billion of support for companies back into the UK economy. Jobs saved, again, we are very focused on creating and saving jobs within healthcare and life sciences, and you can see that number at 10,000. And with regards to our return on investment and the benefits that we bring UK PLC, we have delivered a 3-to-1 ratio using the Treasury Green Book. So very much focused on delivery, driving efficiencies and driving economic growth within the Health Innovation Network. Thank you, Annie. So just to position where we are We very much focus on national problems and national initiatives, but with local understanding. So we have 15 health innovation organisations throughout England supporting at ground level locally, but also building into a national network. We're very much fully embedded in our local system, and we work very closely with our research ecosystem partners as well through universities and the NIHR organisation. And we very much focus on driving economic prosperity and growth in all parts of the country, again locally and with the evolving local authority model, but also at national level as well. This slide, I won't go into any great detail, but we work with a whole host of organisations, from our commissioners to the National Innovation Service, which is supported by the Health Innovation Organisation, which is a key front door for innovators coming into the NHS, right the way to local health and care systems locally, which I've mentioned already, and also at the 9 o'clock in the clock face, the partnering and funding support schemes, working with industry like the ABPI and others within both small and large industry, and also working with SBRI and other funding programmes as well to help support and embed SMEs and early innovators come into the system and work with a range of stakeholders. So again, very important, the breadth of and scale that the Health Innovation Network operates on and across. Thank you, Annie. So with this, I will hand over to Brian from the ABPI, who will take you through the next phase of the webinar. Thank you, Brian.
Thank you, Nicole, and thanks for the warm introduction. Good to see you all, and a big thanks in particular to the Health Innovation Network for convening all of you, and a particular thanks to all of you for making the time at what is undoubtedly a busy time for everyone. As Nicole says, my name is Brian Duggan. I'm Director of Strategic Partnerships at the ABPI. The ABPI, as Nicole says, is the Association of British Pharmaceutical Industry, and we are the trade and membership organisation for the innovative and research-based pharmaceutical sector. So when we talk about partnership working, and that can sometimes be a bit of an abstract term, we have a very well-defined way of how our companies and sector work with the NHS, and we want to use the session with you all now to help explore what that means. And a few practical things that we'd like to kind of focus on as part of the conversation. One is, what's the evidence base for how, when NHS organisations and companies work together and work with one another, what's the evidence base that improves clinical practice, improves prescribing practices, and therefore ultimately improves health outcomes for patients? So that's the first bit that we'd like to kind of focus some of the conversation on. And then secondly, given that evidence base, how do we make these things happen? How do you bring NHS organisations and companies together? And what are the regulatory responsibilities and ways of working that we all need to be mindful of, the NHS as well as the industry, in order to enable those partnerships to actually come to life and make happen? So my colleague Nabil, who I'm going to hand over to in a second, is going to walk through some analysis that we've conducted with Carnell Farah, an analytical firm, with the King's Fund, who will be familiar to all of you, and then some guidance that we produced with leaders like yourselves, NHS Confederation, to walk through how we bring those partnerships to life. And in practical terms, we can look at that guidance through the lens of primary care settings, through secondary care and trust settings, and or through ICSs too. And equally, the Health Innovation Networks can be a vehicle by which we can bring those together. And then lastly, as Nicole had said, I'm really excited to hear again from Jay and Siobhan, who are going to bring that to life, because it's all very well and good hearing from me sitting in an office in London, but it's more important that you hear from people who have walked the walk, not just talked the talk. So a practical example from Eli Lilly and Manchester on how we've supported patients through a collaborative working arrangement in Greater Manchester on obesity, which is obviously the topic of the day. So a huge thanks again, as I said, to Nicole and to the HINS for convening the conversation. And we will walk through all of those reports and guidance. And someone's asked a question in the chat. The vast majority of the content that we'll walk through here is already in the public domain, but I really hope that we can kind of walk it through and bring it to life. And then we'll make sure that all of the content is shared with people after it, because what I really hope people take away from this session is an increased understanding of the evidence base, but also an increased understanding of how to make it happen and how to use those guidances that exist, and why the case studies in the guidance and that we'll walk through in the session are so important. Because it's all very well and good reading a piece of guidance in a piece of paper, unless you see and hear how people have brought that to life and made it happen, it can sometimes feel a little bit abstract. So hopefully you will gain all of those things from the session. So if I can hand over to Nabil to walk us through those guidance pieces and the evidence.
Thank you very much, Brian. Really great to be here. And good morning, everyone. My name is Nabil Rastani. I'm a Strategic Partnership Manager at the ABPI. So really great to be here, as I say, and I'll be talking a little bit around something that's increasingly becoming more central to NHS transformation and patient care, which is collaborative and joint working partnerships between the NHS and the life sciences sector and industry as a whole. And as Brian said, we'll be talking through a number of different elements outlined on the slide here. If we can just move to the next slide, we'll talk in particular around what is outlined within NHS industry partnerships as a whole. So if we take a quick step backwards, partnership working between the NHS and the pharmaceutical sector in particular are really formal collaborations that take place, and at the core of which they aim to really address shared priorities at a local and a national level, whether they be focusing around improving service delivery, tackling long-term conditions, or reducing health inequalities. And as Brian articulates, partnerships are applicable towards various different healthcare settings. So they take place at an ICB level, which is the example that Siobhan will talk and Jay will talk us through later, at a secondary care level. And we also have one primary care example that we'll very briefly touch on as well as part of this conversation. And as part of this process, partnerships aren't just about transactions or sponsorships. They really involve a genuine pooling of expertise, of resources, and those shared objectives. And they're framed around what we call a triple win, if you will, which is a benefit for patients, a benefit for the NHS or healthcare organisation involved, and a benefit for industry. So that real kind of massive gain for all different parties and stakeholders involved. So at the core of which we have joint working, which was established in 2008 and is typically slightly narrower in its focus, and it really focuses on directly benefiting the patients and focuses mainly around, as I say, patient focus, so kind of improving clinical pathways or rolling out of new treatments. Collaborative working is slightly broader, and it was introduced in the 2021 ABPI Code of Practice, which is something I'll talk about shortly. And these projects might focus on improving patient outcomes or system efficiencies or workforce capacity, but they still at their core must also benefit patients, or at least maintain patient care and deliver some value to industry. So again, that kind of triple win approach that we discussed earlier. So if you think about joint working, I see it as a kind of precision focus, really laser focus in its approach, really directly focused on patient benefits. And collaborative working is a little bit more wider. It's a bit more wider in its scale, in its strategic alignment, and often taking place at that wider system level approach rather than that just a primary care or a secondary care approach. If we're able to move to the next slide, please. So we've spoken a little bit around the kind of broad mechanisms in terms of what a collaborative or joint working arrangement is, but how do we ensure that these partnerships take place in that ethical, fair, and non-promotional manner? Enter ABPI Code of Practice, specifically Clause 20, and this is the kind of key mechanism, the Bible, if you will, by which partnership working takes place. So all collaborative workings must operate within this environment. So the Code of Practice really underpins all partnership working, and they all have to be compliant with this Code of Practice. And there's a couple of bits of criteria that we've listed here as part of that. So really, as part of which they have to be delivered in a transparent and clear manner. They must not be an inducement of particular medicines, and they have to be transparently reported. So both in terms of at the end of the project, 6 months after which there has to be an executive summary and summation report being published, but also published on a Disclosure UK to ensure that all values involved in the project are transparently reported as part of that process. So really ensuring that all elements of which are clearly recognised as part of that process. Could we go to the next slide, please? One more, please. So just to continue, and this articulates and builds on what Brian mentioned earlier, around the kind of evidence base. So last year, the ABPI really worked to identify and understand what the impact of partnerships are across the 4 nations of the UK. Prior to this, we understood at kind of tangential local level how partnerships had an impact, but not really at the aggregate level. So to achieve this, we worked with Farrer, which many of you may know is a data analytics firm, to really evaluate the aggregate and quantitative impact of how partnerships actually benefit patients. And their findings were particularly interesting across care settings. So they show that where partnerships have taken place in hospitals, they're more likely to result in prescribing medicines closer in line with NICE recommendations for eligible patients, and that had a concurrent impact on health outcomes. Similarly, at a primary care level, those organisations involved in partnerships saw kind of patients being associated with improved disease management from conditions like high blood pressure, which of course relates to those shifts. So shift 1 in particular around moving care from hospitals to communities, and I'm sure we'll see a lot of that with the publication of the 10-year plan. So a lot of significant gleanings drawn from this, and just to say, a really brilliant 1-page document summarising all the findings of this paper have actually been published, and we can share that as part of the aftermath of this call as well. Next slide, please. So if we just look in kind of a bit further along, so we've talked a little bit around the kind of quantitative assessment of partnership working and the impacts they have. If we look a little bit more on the kind of qualitative assessment, so the King's Fund produced a report in November last year, which further evidences the impact that these partnerships have. As I say, this time focusing more on the kind of qualitative assessment and focusing on 4 specific partnerships across a range of different therapy areas and care settings in England. And in particular, they had a range of different examples of how they had a positive impact, both on NHS organisations, but patients in particular. And there's one really strong quote that I think stood out for me in particular from that report. And it's one of a example of a hepatitis C partnership, a collaborative arrangement that took place. And I'll just really quickly read out the quote actually that was mentioned by the NHS leader involved. And it said, "In terms of anything I've been involved with in my career, this is one of those things where I can tangibly say has saved many lives. These are thousands of people walking around that would now have been dead. I remember early in my career, 20 years ago, when hepatitis C wasn't much more than a laborious or access was very hard to get. People died, lots of people died, and now they're much less likely to. So that alone is huge. It's significant. It's game changing. That's the biggest benefit by a long, long way." So that's just one example of an NHS leader who saw a really powerful, demonstrable impact from a partnership arrangement, quite literally saving lives. And I think that, as I say, really articulates the human impact that these collaborations have had. Can we go to the next slide, please? So now we've looked a little bit around the why aspect, around kind of why they're useful to actually take place. It's kind of helpful for us to dive a little bit in terms of the kind of operationalization piece and the how element of how partnerships take place. And as part of this, the ABPI and the NHS Confederation worked last year in June time to produce new guidance on how partnerships are actually developed and facilitated. And I won't dwell too much on this slide as it's quite a complicated looking slide, but it's just a timeline. But it's helpful to visualize the history by which guidance has existed in England around partnership working. So you'll note that the first piece of guidance was developed back in 2008, following the introduction of joint working, and the process was kind of developed up until 2021, where we had the introduction of collaborative working. And in particular, you'll see in November 2023, a local NHS system, Cheshire and Merseyside in particular, developed their own guidance on how partnerships work. So that was something that we really sought to rectify when we developed this newest guidance in 2024, was to alleviate some of those burdens on healthcare systems in particular. And as you can see at the bottom of this slide, each piece of guidance was really underpinned by the ABPI Code of Practice, which again serves as that guardrail by which partnerships must take place. And that continued right way through as part of the newest guidance that we developed this time last year. If we're able to move to the next slide, please. And this is just a helpful kind of breakdown in terms of the process by which we develop this guidance. So we brought together a range of different colleagues from primary, secondary and system levels, from industry and NHS perspectives, to really ensure that we could stress test and ensure that as part of this development of the toolkit, that their views and opinions on how partnership taking place could be integrated, so that we could take those best learning practices as part of this process. So you'll note the kind of breadth of different individuals. Over 30 or so individuals took part in those sessions. If we're able to move to the next slide, please. And just finally, on the guidance, so this year we went a little bit of a step further and developed a really easy one-pager, which you'll see on the screen, with the NHS Confederation, which highlights the kind of top-line approach by which partnerships are actually delivered, for those who kind of want a little bit more of an easier and digestible version of the guidance. In terms of the actual guidance itself, I think there's 4 key areas that it sought to improve on from previous iterations of guidance. The first, as I mentioned, is around consolidating all the existing guidance that was in place into one document to ensure that we have a kind of coherent and standardized mechanism by which to understand how partnerships take place, but also, as I say, ensure that individual systems don't have to develop their own guidance, and that they're really clear and we have a robust mechanism and framework by which we can actually understand how partnerships are actually implemented right from the starting process through to the kind of final operationalization side of things. The second is around ensuring that we highlight the essential role of the ABPI code of practice as part of this process. As I say, again, it's a real guardrail by which all partnerships need to take place, and that really ensures that there's a robust process that underpins them. So that's the kind of second piece. The third, and this is a really great addition that we had, is we've also included a range of different framework template documents that includes things like project initiation documents, collaborative working summaries, project outcome reports, among others, that really ensure that when an individual who might not understand how partnerships take place or haven't undertaken them previously, know really good quality, robust best practice documents which have been co-branded and co-developed by the ABPI and the NHS Confederation are available for use and across therapy areas and geographies. And that really ensures that you're able to navigate partnerships in a really clear and coherent way. And again, that standardized approach as well. And finally, just to really kind of ensure that we have real hard evidence as well in terms of the impact of partnerships and how they're operationalized, we've got 3 case studies from a primary, secondary and system level included within the guidance, which focuses on the kind of operationalization of how they've been successfully implemented, and also how learnings can be drawn from them, how they can be replicated and how they can be scaled, and the step-by-step process by which they were actually implemented. So not only do you have the kind of literature and the guidance and the templates to back you in terms of developing the guidance, but also a clear practical example of how they've been implemented previously. If we're able to go to the next slide, please. And just in the last couple of minutes or so, before we go to the Jay and Siobhan, I just wanted to highlight one specific case study in a primary care setting that really demonstrates the triple win for patients, the NHS and industry. So this partnership was a collaboration between AstraZeneca and Health Innovation Manchester and Lung Health. So 3 partners involved in this project, which aim to improve asthma care in Greater Manchester, which has a kind of higher asthma prevalence and worse outcomes than the national average, and that's often linked to deprivation. So as part of the project, Health Innovation Manchester oversaw the project, overseeing its day-to-day operations, recruiting GP practices, supporting the implementation, while AstraZeneca kind of supported with funding specialist nurses, providing the training in primary care and using their expertise in data analytics to really identify at-risk patients to measure impact. And then concurrently, you had the patient organisation, Lung Health, providing the kind of guided consultation for asthma reviews, along with wider training and project design as well. And through the project, which focused proactively on identifying patients with poor asthma control, there was a real optimization of their treatment. So over 1,000 patients actually received asthma review helping them to really gain a better control of their own conditions as well. And so many patients were given a kind of personalized action plan for their asthma, and that really provided them with a clear guidance in terms of how they could actually manage their treatments. So that's just one example of kind of a successful collaboration that took place at that primary care level. So just to wrap up before I hand back to Brian, as I say, NHS partnerships are not about sponsorship. They're about the shared values and shared goals. And the ABPI Code of Practice provides that ethical and legal framework by which to underpin partnership working. And the evidence base is very much growing in this space, showing real world improvements in patient care. And then when you have that coupled with the guidance that we now have those practical resources to build more partnerships to take place in that robust manner. So with that, I'll hand back to Brian.
Thank you, Nabil. Very clear and very comprehensive. At the risk of repeating Nabil, I do want to kind of just reinforce some of those lessons that we certainly learned and feedback that we had from NHS leaders when we embarked on that journey last year of co-developing that piece of guidance. And there's 4 things for me that really came through when we started to write this. First, that it was so important that the guidance itself was co-developed and co-owned. The previous guidance that this publication builds on was an ABPI publication, useful for the industry, supported by the industry, but it was less accessible to NHS leaders. So what we wanted to do in refreshing it with the NHS Confed was to listen to, learn from, hear from NHS leaders, and to build something that was as useful to lift off a shelf in the NHS as it would be in a company. So that's kind of one thing I just want to reinforce. Second, as Nabil indicates, that there is one version of this guidance applicable to the whole of the NHS in England. So rather than people in your organisations having to start from scratch and write a piece of guidance yourself for your own ICB or your own trust or your own kind of PCN, having one piece of guidance that you can draw from that's applicable across the whole of the NHS in England. It's been signed off by David Webb as the chief pharmacist. Amanda Pritchard, when she was the NHS England CEO, issued it in a bulletin out to the health service. It's been reviewed by the PMCPA, who are the regulatory authority responsible for the code of practice. There is one version that you can all use, confident that it has the right regulatory responsibility set out and is endorsed by NHS England. Thirdly, as Nabil indicates, it has those templates built in it. So you don't have to start from complete scratch in developing those templates, writing them from scratch. Companies have provided them, NHS organisations have provided them, and we've embedded them within the document. So you have somewhere to start. And then fourth, it has case study examples in it so that you can understand how people have been on this journey before and worked their way through it. So those are the 4 things I just wanted to kind of reinforce a little bit through what Nabil has walked us through. And now, talking of case studies, that seamless, brilliant link, I want to hand over to Jay Hamilton, who's the Business Development Officer at Health Innovation Manchester, and Siobhan Ainscough from Lilly UK to talk us through their case study and their work on obesity in Greater Manchester. Thank you very, very much for joining us and walking us through the case study. Always brilliant to hear about this work.
Thank you so much. So we're going to do a double act here, but before we get into the absolute depth of the obesity work that we undertook with our partners at Eli Lilly, I'm going to offer a little bit of context because I noticed at the upfront when we did the poll, the different representations on this webinar, and I think it's important that we look at this case study but acknowledge that the case study is underpinned by a methodology that is linked to the ABPI Code of Conduct, to the expected standards that the NHS would want us to operate any public and private partnership. So for that reason, my first 3 or 4 slides will give that context about the importance of frameworks and within these public and private partnerships, and then we'll get into the actual case study of obesity. Next slide, please. I just pushed my button to move to the next slide. So Health Innovation Manchester, like the other health innovation networks, are here really to help accelerate and provide the environment in which which innovation can thrive. And to do that, like the other HINs, we platform a number of very key and critical pillars, as we like to think of them. We make sure that our governance is integrated fully, not only with the governance of our partners, our private partners and the ABPI, who oversee and give guidance as to what that governance needs to look like, but also our system and NHS governance. We have integrated capabilities, and I'll talk a little bit to that. And when I talk about integrated capabilities, that's not just within the HIN network, or indeed within HIM, but also within reaching into the capabilities of our system, of our voluntary sector, of our partners at national level, as well as our partners in industry. And this applies to all the partnerships that we undertake. We have an unrelenting, and that's a deliberate word, it's not there for drama, it's there for emphasis, an unrelenting focus on method. So what we do, we repeat, and that can be transported to any other ICB or any other HIN, and other HINs do this with us as well. It's to create blueprints, so we have an absolute focus on methodology. And importantly, we see industry partnerships not as a nice to do element to bringing accelerated access to innovation into the UK health environment, but an absolutely critical factor. Next slide, please. So I talked a little bit about the governance, and I talked a little bit about our integrated capabilities. And you can see there that we're made up of a team of people that are not just about delivery. We have a dedicated team that do digital and data and link with our partners, Lilly in this case, but other partners with their digital and data teams. We have an operational element to our organisation, a clinical, an academic, and I lead on the commercial side. So we really do think about the different departments within our Health Innovation Network that are required to bring all the correct capabilities to the table to deliver at scale sustainable programs through private public partnerships. And that takes into account the lens of people, process, culture, as well as tools and technology. Next slide, please. So this is where we start to translate good governance into good practice, and I will take you through how we do this at Health Innovation Manchester, repeated every single time we open the door to a discussion with a partner like Eli Lilly. We would go through this whole process as thoroughly each and every time, and then overlay this with how the ABPI and the way that Siobhan and the team and others who I see are on the call from other industry partners that we have would operate. So we ideate things. We decide whether or not the thing that we're talking about fits a good logic model approach, i.e. can we really talk about the problem we're trying to solve? And we talk about these triple wins. So the beginning of our logic model has to say, is this a legitimate problem that the NHS is facing, that patients and public have gaps and we could improve? And if it is, what's the policy that's sitting around that will help us in our attempt to transform existing pathways into new pathways? And then what would be the activity that we and Lilly or Boehringer and Novartis, whoever we were partnering with, what would be the activities, the outputs, the inputs, and the impacts that we'd be looking to generate? So that whole logic model approach to gaining good evidence, again, back to things that both Brian and Nabil have talked about, the need to prove that working together in partnership has evidence behind it to say it's the right thing to do. It's a good use of our time, it's a good use of the partner's time, because ultimately systems and partners and patients alike all benefit in that triple modality. You can see once we move through each of those gateways, the governance and the depth of our documentation and rigorous assurance increases, as you would imagine. That does mean, of course, that when we enter into these kind of partnerships, some fail very early on. They never make it past ideation because some of the factors, whether it's system readiness, affordability, partners, shared ambitions, don't match up. And if that's the case, then we move swiftly on and relocate that innovation somewhere else. Next slide, please. So just sort of overlaying, if you like, we recognise very quickly that while we have an internal process that we can stand up in front of our ICB and our patients and the public at large, we also need to make sure that that methodology has a linkage and a very clear pathway that is overlaid by the ABPI Code of Conduct, the governance under which all of our, or the ABHI Code of Conduct, which all our partners adhere to. So we're always trying to overlay one thing with the other so that our intentions can be assured and can be documented and can be evaluated in a way that is safe and transparent and able for everyone to see and be assured on. And that often includes us pulling together very senior members of both the private as well as the public partnership. We always would have an SRO from both the system, so that's a GM system, as well as Health Innovation Manchester, and very senior leadership from the partner organisation, in this case, Eli Lilly, to form part of a steering committee so that all of our work is evaluated on a regular and transparent manner. Next slide, please. So let's get into the case study. This is an important slide in as much as we have an overall organisation mission, and one of our strategic objectives here is to address high priority population health needs by deploying innovation at scale. And under that, obesity, notwithstanding, is one of the key areas. Next slide, please. Just pause for a moment if anybody was in any doubt, and I think you'd have had to live on planet Mars not to understand the impact that obesity is having on global health outcomes. And the innovation of GLP-1 agonists is already revolutionising care, not necessarily in the way that we had hoped or imagined in the NHS, but it's certainly in the out-of-pocket market. We're seeing a huge response to these medicines, and timid response, should we say, to these medicines because of the sheer size of this issue and the impact that that will have on the NHS as a whole. So a very cautious approach to how we're addressing this global phenomenon. As you can see there, 4.32 trillion is the estimated cost of looking after people living with obesity by 2035, and that's comparable to the cost of COVID-19 in 2020. So if any of us are in any doubt as to the economic impact of global obesity, then I think these figures lay stark contrast to why we need to think about all of the things that we need to think about, including treatment to prevention, hospital to community. We understand the triple requirements, and analog to digital will all play a part in helping here. But this is an emergency issue, a crisis for the world. And we saw that, and we started some 2 years ago talking to all of the companies that were involved in dealing with obesity, and that led to a very formal partnership with Lilly. Next slide, please. Through that partnership with Lilly, we were able to utilise shared capabilities, shared funding and shared approach, and actually worked with a company called Frontier, which many people will be familiar with. It's a nationally recognised health economic organisation who worked with us to do some very detailed understanding on the impact of obesity in Greater Manchester. we've left unchecked. And I think there the numbers start to give you some indication of just how important an issue for both our workforce and productivity, as well as our health and health outcomes, that obesity will place on our system, and is placing on our system already. £3.2 billion is spent or lost on obesity in Greater Manchester every single year. And Nabil mentioned before, when talking about our respiratory programme with AstraZeneca, just how deprivation often is linked very closely with some of these very poor outcomes for long-term conditions. And you can see there that Rochdale, Oldham and Tameside, three of our areas, are showing over 30% of those populations living with obesity. In addition to the health economic evaluation work we were able to do through the partnership, liberating those funds to do that very detailed data analysis, we also undertook some work with an organisation, again a preferred partner for both Lily and ourselves, called Tranoka, and we did some qualitative and quantitative assessment of the current tiered services. Why did we do all of this work? What was our aim in doing this when NICE had already said that GLP-1s were important and that they would be cost effective? Well, we believed really strongly, having experienced the Novartis and lipids optimization work, that without thoroughly understanding what your current system demands and pressure points are, it's very hard to know how to land new technology and gain optimal access to those new medicines or technologies in a meaningful and sustainable way. So we undertook this understand work in order to be able to do the next phase of the programme when the medicines were launched, and we've seen all of the noise around the funding variation and very limited access to medicines. So we wanted to be as ready as a system could be to how we would respond to the introduction of these new medicines, and how we would use different service models to move that care from this broken tiered system into a more usable digital first integrated service that we would reimagine for the future. So next slide, please. And as you can see here, I just talked about the broken nature of the current system. When we took a deep dive into the current status, and I think that everyone on this call, whether you're from Birmingham or London or Dorset or indeed Manchester, will recognise this picture. Wherever you are in Greater Manchester, your access to obesity care would differ massively, even within the same practice. The same levels of care and understanding of service availability is disparate at best and broken at worst. So we've got this very sporadic, very fractured system that's groaning under the strain of demand. We've got people waiting in excess of 18 months to be seen, some waiting on bariatric waiting lists, etc., and no one knowing quite what to do. So we wanted to understand all of those pain points fully. Next slide, please. So having completed on the your left, my right, the discovery piece of work, and having published, and if anyone is interested, all of the work that we did is published on the HIM website, including the Frontier Health Economic Evaluation. We've now readied ourselves and working again with funding and support from colleagues from industry, and Lily in particular, to reimagine what the new pathway, with some of those thoughts in our mind about treatment to prevention, about hospital to community, new ways of working using new models of care in that space, and of course digital being at the forefront of our thinking. We're now working with a deeply integrated model and an agile approach to reimagining and redesigning a new obesity service that will allow us to go somewhat further, somewhat faster than the proposed funding variation, which I'm not sure how that translates in other people's ICBs, but for us in cohort 1, we have approximately 3,500 patients of our 600,000 patients living with obesity who are eligible under that cohort, but under the funding, approximately 900 of them will be funded. So we've got a very big mismatch. So we're trying to move the dial through our partnership working and building a good business case for why and how we do things differently, working with our industry partners and all the expertise that they bring, and with our ICB colleagues to do just that. Next slide, please. I think this might be my last slide, and just to say our work is a user-led design. I think it's my penultimate one, apologies, is a user-led design, and within our groups now, and we're on I think our 5th workshop now, we have bariatric surgeons, commissioners, heads of finance, we've got public health, we've got public affairs, we've got GPs, we've got nurses, specialist carers, as well as providers of some of the digital solutions. So we're working on 5 different work streams to really ensure that our system can be as equipped and able to build a business case for why it's important that these GLP-1s are made available to the optimal number of patients. Think my final slide, and then I'll hand over to Siobhan to give a view of what that feels like from an industry partner perspective. So this is a person-centered approach to our design thinking, and I think it's really important for us all to pause and think about, if we want to introduce new technology or new medicines, or optimize the use of technology and medicines that are already in existence, then we have to think really upfront about how, when we pull away from the traditional partnerships that we've had with industry in the past, things like producing and providing extra workforce through community pharmacy, external providers of service, etc. How do we leave a legacy behind that is felt by the system to be one that they designed and wanted? So that's a really important aspect of why we take this approach to person-centered ideation and creativity, iterative testing, because what we want to build with our industry partners and with our system is something that will last beyond the injection of additional enhanced resources that we often see in the early parts of a partnership with industry. So that's why we take this approach. I'll ask Siobhan when she begins to comment on how many people put that in the too hard to do box and just crack straight into solutions, and we take our system on a journey, how that impacts the time. And I think I've seen other colleagues on the call who are working with us on other big ICB-led projects. And again, I think we call it our iceberg approach. It takes us longer to get to the start line because we bring partners along the journey with us in that design and design of outcomes and intentions. But once we get off the start line, we can pretty much say with some guarantee that we're all in it together, and therefore when we pull away and we've proven our case, the case continues beyond that injection that cannot be sustained forever throughout the life cycle of a programme. So Siobhan, I think it's over to you now to give us your view on what it's like to work in this space.
Yeah, thanks, Jay. So I'm Siobhan. I work for Lilly. My role is NHS Partnership Manager. But I am here really speaking on behalf of industry. I'm privileged to be asked to speak, but there are an awful lot of organisations who currently work with Health Innovation Manchester as well. So I do speak on behalf of all of us. As an industry, we put an awful lot of resource into our pre-marketing authorisation programme of clinical studies. And through that, we demonstrate the value of our medicines in terms of safety and clinical efficacy. And then post-marketing authorisation, we also have a lot of resource through the NICE process, and that demonstrates the cost effectiveness of our medicines. Unfortunately, having a cost-effective medicine is not enough anymore. Our medicines need to be affordable in a fragile NHS at scale. So that's the problem that we're trying to solve in terms of partnering with the NHS. So what we need to do is demonstrate the value of our intervention to the system, aligning, Nabil referred earlier to shared value and shared goals. So we need to align with the NHS priorities. So through our collaborative work, we need to support the prevention agenda. We need to keep people out of hospital, increase access to digital tools, reduce pressure on the system. And through that, every organisation, industry organisation, will have somebody in my role. It's a non-promotional role because we have to align with the ABPI code. So all of our collaborative working is non-promotional. So what do we do in terms of aligning that value and aligning those priorities? So we look at the current pathway, we look at the burden of disease on the system, we look at the consequence of doing nothing, medium and long term. We look at potential reduction of demand, reduction of inequalities, sustaining financial balance, and through all of those priorities, that's how we reach a stage where we can partner with the NHS and have aligned goals. So just move on to the next slide. I've only got 3 slides, so I won't be talking for too long, but in Lilly, and again, it will be the same for other organisations, we have 3 fundamentals that our collaborative working project need to deliver on. So ours are ensuring access to diagnosis and treatment for eligible patients, reducing health inequalities, and tackling clinical inertia. And if we move on to my final slide, I can show you what this means for metabolic health. Oh, that's not my final slide. I did have a final slide somewhere. There it is. So this is the metabolic health slide, but we have these roadmap slides for all of our therapy areas. So if you look at the bar across the middle and think about obesity, you've got awareness, seeking help, diagnosis, treatment, and ongoing care. But that journey is the same for the vast majority of long-term conditions, although this specifically refers to metabolic health. You can overlay that into any of our long-term conditions. And then if you look at the curved line, the dotted line, this is the patient journey, and the red dots are potential partnership opportunities where we as an organisation, as an industry, see the opportunities to partner with the NHS. So I'll work my way through the dotted line. So you've got the initial self-management of a patient, so before they actually present. Then you've got the recognition of obesity as a disease. It's not necessarily recognised as a disease. It can be seen as a burden to the NHS. Patients may see it as a burden themselves, which leads to stigma. So that's an area where we have actually off-the-shelf solutions for that. We have an education programme on language and stigma, and I'm sure other industries and other organisations will have similar tools. And then we work our way down to the initial consultation and diagnosis section. So potentially demand for treatment could overwhelm services, again, not just in metabolic health, but in all long-term conditions. And then working right the way through, you've got the treatment decision, which we don't take a part of in the NHS partnership role, the weight management services, and then you look at the initiation of the treatment. So once that decision's been made, what is the burden on the system of starting and monitoring treatment on the healthcare service and on capacity? And then, of course, Jay referred to the ongoing monitoring support as well. So that's how we make our decisions in terms of what are the opportunities, where do we partner, where are our resources best maximised, and how do we align with NHS priorities? And then the final point I wanted to make is about working with Health Innovation Manchester. So in order to collaborate, industry needs to have an open door to the NHS. We need to have an open dialogue. And the warm welcome which industry is received at Health Innovation Manchester, I'm sure other organisations are the same, I'm just speaking from experience, but the warm welcome is incredible. The door is wide open, not just for Lilly, for all of my colleagues in Boehringer, in AstraZeneca, in Chiesi, in Novartis, because Jay mentioned the ideation phase. Projects are allowed to fail. And that means that we can therefore have that conversation with the understanding that if it doesn't work, that's okay, but just come and talk to us. So the culture at Health Innovation Manchester is very much, we are partners, we are willing to work together, we're willing to listen, and the result is clear. You can see the slides that Jay just presented, but that's just one example of successful industry partnership, and there are many, and it's a direct result of that culture.
Thank you. And I think your point earlier, I've noted it down, is let's understand the problem we're trying to solve, I think is key. Jay, thank you very much. We've got several points in the chat around how do we look at this locally, how do we work with our research bodies locally, etc. How do we maybe engage with SMEs or larger industry? Please do reach out to your local health innovation organisation within your region. Details will come out to those on the call. Also, we'll obviously be posting all of the resources that Brian and Nabil spoke to. So that coming from the effective NHS partnerships and also the King's Fund NHS and Life Sciences Industry Partnership Collaboration to Improve Care piece of work, and the other articles that both Brian and Nabil posted in the chat, so they will be sent afterwards. There isn't a problem with that. Please do reach out. That's what the HINs are here for. Also, I know that in consultation with our ABPI colleagues, they're also very happy to take questions through the HINs and industry partners as well. Thank you, Brian. Thank you to everybody, and have a good afternoon.